sudden cardiac death in young athletes. So probably the single most carrying part for any athlete or a pro sportsman is going to be on this event. Okay. So these are the objectives which we are going to look. So sudden cardiac death in young athletes, what is the etiology behind it, what are the reasons for sudden cardiac death, prevention strategies. We'll be looking into how cardiac screening and pre-participation evaluation can prevent such events from happening. When some catastrophes happen on field, we need to be prepared as sports physicians. So we'll look into how the preparedness can happen on field and also in the sideline. And an important thing with sports physician is the role of RTP or return to play. So you need to know about the updated return to play guidelines. And with sudden cardiac death, usually the diagnosis itself happens in, unfortunately, in an autopsy. Okay? So you also need to, as sports physicians, we need to know the etiopathogenesis behind it, and that's where the role of autopsy and forensic pathology becomes very important. So we'll be covering all this during this presentation. So most of this, if you see most of the sudden cardiac arrest and sudden cardiac death has been well researched in predominantly in this sport, football. So that's where a lot of research has happened. And football medicine itself has been coined. And we all would have come across this event in last year, the event of Christian Eriksen. Unfortunately, the video is not playing. So the event which happened in UEFA last year in 2021, and how the Danish player suffered an unfortunate on-field sudden cardiac arrest. And luckily, the role of sports physician becomes even more important when the Danish sports physician were able to do a proper job, okay, on field, and was able to revive him, and luckily there was no sudden cardiac death. So though there was sudden cardiac arrest, there was no sudden cardiac death. So this becomes the most important role of a sudden sports medicine physician or a team physician. If it has happened in a unprofessional setup, the left pic, if you see, is an unfortunate event which happened 2 decades before in Indian soccer field, where there was a collision between the forward and the the goalie, and the unfortunate, the player had passed away due to improper management on field. So as a budding sports physician, you all need to be thorough with how we can prevent it and how we can manage it. Yeah, so, yeah. So data after COVID-19 is even more alarming. If you see, there is a lot of pros and nays when it comes to COVID. The data being shared as far as the COVID vaccination, and whether the COVID vaccination itself is causing sudden cardiac arrest or cardiac events, or the COVID itself is causing increased incident of sudden cardiac arrest. So both this data becomes very alarming post-COVID-19, and the role of sports physician is very, very important, and to be aware about how the vaccine, the data after vaccine results becomes very important. So if you see the history of sudden cardiac death, the research has happened pretty extensively, more than 100 years old. Okay, right from 1899 in Henson in Sweden, they did a study in skiing and competitive skiing, all the way up to this century. In 2005, when Bethesda conference happened, and there was a proper pre-participation guideline screening, which was updated for athletes. And both AHA, American Heart Association, and European Cardiology Society comes with updated guidelines on sudden cardiac death. Okay, so you need to be aware about the history for us to be well prepared about these catastrophic events. If we come to the etiology or the cause of sudden cardiac death, the common causes still remains HOCM or hypertrophic obstructive cardiomyopathy. The role of myocarditis after COVID-19 is becoming increasingly significant. These are some of the etiology. Age greater than or equal to 35 years, if there is any event less than this age group, then it becomes very critical. HOCM, myocarditis, and other. One important feature which we come across on field is event of commercial-carditis. Commercial-carditis is when on-field collision happens in sports like rugby or lacrosse. Luckily, it's not so common in the Indian setup, but pretty common in European setup and in South African rugby and football. Okay, where there is during a very short cycle of cardiac cycle, when there is a collision between a particular hard object, need not be a hard object, even a soft object, because the pericardium, the cardiac muscle is pretty pliable. Okay, so when that hits and at a particular point of cardiac cycle, a typical ventricular fibrillation can happen, and that can result in sudden cardiac death. So commercial-carditis is something which every sports physician should be aware about. So should we have pre-participation screening? There is enough and more data through all this 100 years study which is clearly proven that yes, we need to have pre-participation screening. If you see the 3 decades study right from 1980s, this is a very famous study by Kuroda in European Heart Journal. It was published in 2005. Over a 3-decade study, it very clearly proves that pre-participation screening and cardiac evaluation has been conclusively been able to prevent the sudden cardiac death. If you see the graph between comparison of athletes and non-athletes, it's gradually coming down, and it's been equal to the common population. So it's very clearly, conclusively proven that a good pre-participation evaluation, especially by a sports medicine physician, becomes very, very important. Look, we even have in our own setup here very recent episodes. We are having a very famous football legend coming today, gracing the inauguration session, Mr. Raman Vijayan. And we have had recent episodes post-COVID when there has been a lot of incidents happening in early 40s and late 30s in that particular age group, and it is alarming. So that is where the setup of having a physician covering a sporting event is paramount importance. Now, how do you do a cardiac screening? So, young competitive athletes, we recommend anything between anybody from 12 to 35 years with a family history of cardiac event to undergo a proper structural sports medicine physical evaluation and a 12-lead ECG. And if there is any positive finding, a further cardiac evaluation, preferably with the echocardiogram, is recommended. So, in addition to prevention of sudden cardiac death, this evaluation will also help us make a small differentiation, because predominantly athletes have something which is unique, which is called athlete's heart, and that has to be differentiated from a pathological heart. Okay, so there's a small gray zone. So whether in terms of LV wall thickness, usually the athletes have, if athletes have anything less than 12 mm, but in hypertrophic obstructive cardiomyopathy, it can be more than 15 mm thickness. But there is still a gray zone between 12 to 15 mm, which has to be properly scrutinized and evaluated. So this evaluation will also help in preventing the athlete's heart, to differentiate between athlete's heart and pathological hypertrophy. So as I said, American Heart Association also comes up with recommendations. The recommendation is slightly more lenient compared to the European guidelines, where they graded it low risk, moderate risk, and high risk. Low risk being any men less than 45 years. The age becomes a significant risk factor, and that's being reduced more the event happening in lesser age group, less than 30, the significance becomes, the higher chance of cardiac event happening becomes even more important. So as a sports physician, when you do a pre-participation evaluation, what are the symptoms you should be seeking? So you don't need to go straight away to all the fancy evaluation. As a physician, stick back to the basics. Can you ask questions like, do you have a heart murmur? Do you have HOCM? Do you have Wolff-Parkinson syndrome? Do you have long QT syndrome? These are rubbish questions to ask. Even though you might be very good in sound in theory, if you ask such questions, the athlete might not be able to answer. More important would be to ask questions like relevant questions. Ask relevant history when you're doing a pre-participation evaluation. Have you ever been breathless? Have you felt weak on extreme exertion? Have your chest felt tightness and discomfort? Have you ever felt tired after training and performing? These are all relevant questions which an athlete may be able to relate to. So when you do a history, do ask relevant questions, because pre-participation evaluation done by sports physician I have seen, either it goes for on and on, because you need to not only do a cardiac or a systemic examination, but you also have to do a MSK evaluation also. So if you are running through the evaluation, then you tend to miss out on important findings. But if you are taking so long, you won't be able to cover a lot of people. So it becomes very important to ask the right questions and do the proper examination. Very important, the family history of premature cardiac death, family history of unusual cardiac diagnosis, any history of people saying that the athlete had a murmur, ever experienced blackout. These are all relevant questions. Examination becomes very important. Assessment of body habitus, especially Marfan's habitus. Typically, athletes like Ishaya, this guy is a famous American basketball. If you see the frame, it's tall, sleek, and long arm span. Unfortunately, luckily the sports medicine physician there was able to identify him at a very early stage, and you won't believe he was stopped from playing his professional career as early as 26. So this happened in NBA. So this becomes a very important event. This is the significance of pre-participation evaluation. So even though it is a very hard thing, but you are saving a life. So these are events which needs to be handled by the professionals. Assessment of pulses, blood pressure, and auscultation, both resting and exertional, becomes very important. Investigation. So again, this becomes a consideration and a conundrum. So should I order an ECG? Again, this is important. 12-lead ECG is basic, but I hope all physicians are able to read it. So there should not be any predicament over it. Yes, you should order, and yes, you should not give this to a cardiology opinion for reading the X-ray, unless you have a gray zone area where you find it difficult to interpret. Would it be wise to order an echo? Yes, when you go to an echocardiogram, yes, you need to probably seek in help of a cardiologist so that you can make further inputs out of it. So some of the ECG changes which are common to athlete's heart are sinus bradycardia and sinus arrhythmia. So these are all present in athlete's heart. The uncommon ECG findings are important. If there is a T-wave inversion or a ST segment depression, then that is not part of an athlete's heart, and that needs to be investigated further. So there's a very gray zone where you need to make a very clear definition whom to refer to a cardiologist and whom you can make an interpretation and manage on your own. So the BJSM has come.
Dr. Dobson, you have a minute now to conclude.
Sudden cardiac death prevention, FIFA has come up with good 11 steps. So prevention strategies and then planning and protocol on field becomes very important. So for any on-field thing, the management remains with a BLS. So please don't go for any on-field coverages without adequate certification, preferably a BLS and ACLS. We have been lucky in SAVEETHA Institute to have a fully accredited AHA simulation lab where we have AHA accredited BLS and ACLS certification done here. And importance of team physician kit is also very important. Cardiac collapse, the line of survival is like early access, early cardiopulmonary resuscitation, early defibrillation, and early advanced care. So these are the chain of survival. And on field, it is very important. If you see the Danish incident in Ericsson also, the important CPR was started less than 2 minutes. Before 2 minutes, there was active implementation of AED was done. So this becomes very important. AED has to be started in the first minute itself, and in second minute, the second shock was given. And whereby, so more active intervention is happening, better the chance of recovery. So return to play with HOCM. Again, this is very important. The new findings being young age, more the young age, and you need to reduce the reduces the athlete's chance of returning to participation. So if the athlete had a younger incidence earlier, say for example in 25s or 30s, then it pretty much rule him out from a professional career. Recent advances, there is a talk of genetic testing, a simple saliva, doing saliva testing, which buccal pads saliva testing, which can do a gene-based testing like presence of ACTN3, ACE gene, which might be associated with HOCM risk. So this is not clear, but this is coming up in a big way. So finally, when it comes to definitive diagnosis, as I already said, pretty much SED is diagnosed at the autopsy table. There are uncertainty regarding causes of sudden cardiac death. Current postmortem procedures are inadequate. Different population, whether it's a European population or the Indian population, have different causes of sudden cardiac death. Premature coronary artery disease is still understated, and we are not even close to finding an effective screening. One important slide, which the PGs it will be beneficial. If there is a sudden death, refer to pathologist, and if there is no non-cardiac causes, you can leave it. If there is a cardiac cause, and if the pathologically abnormal heart, then you have to refer to an inherited heart disease specialist for a molecular autopsy. So forensic pathology role is becoming critical. To conclude, pre-participation sports medicine assessment is very important. Sideline preparedness is very important. Sports cardiology has experienced a very exciting development in last decades, vital part of sports doctors' knowledge. A combination of cardiac screening and arena safety measures has potential to decrease this incident. Remember, prevention is very important, but being sports physician, keep in mind it will happen. The events will still happen, so be ready for effective management. So UEFA has honored the Ericsson incident. The doctors were actually pro-badminton players, former pro-badminton players. Thank you for the patient listening. Thank you.
I think I no need to emphasize on this, but just a word for all the budding sports physicians that your AED handling, you need to know it, you need to practice it. And along with that, of course, the CRP. Resuscitation, we all know theoretically, but practically, we must have it. I'll request the organizers that in future, please arrange one small session of 20-25 minutes, for this is a very important and a vital topic. I open this to the House for discussion. Keeping in view the timings that we have it, we'll have 2 questions for Dr. Dobson Dominic. Yes, please.
Yeah. Yeah. More the eliteness of athlete, better to do a conclusive testing. whether in terms of ECG or cardiac evaluation when in doubt. But personally, I would say that the clinical examination becomes very important in Indian setup, and judicious use of investigations is how I manage it. We cannot just like that in an Indian setup constantly write for a ECG and echo as a standard protocol. So history and examination still remains a hallmark, and if you're a good clinician, then you will be able to pick up the clinching points which will help you whether to go for a further investigation or not. That is my line of management. I think the experts can...
Certainly in case of an elite sports persons, at least FIFA has already come out with the guidelines. Every professional sports person has to undergo an echocardiography. I know in our national camps we are not doing it, but I think a basic ECG must be done in case of elite, whether be it hockey, boxing, any sport over there. Sorry? Once a year. Just that much only.
And
we know we can't afford echocardiography for everybody. It is not being done. No, it's not practical, but ECG must be done. At least we used to do it in our sports medicine centers for every athlete. And mind you, it gives you a lot of other things. Seeing the tracings over there, you can see the overloading. We were discussing yesterday the heart rate variability, the T-wave inversions, ST-wave, all those things can be found on that basic investigation. So as the off-season finishes, you see, you must do that. Oh yes, post-COVID I think has become more and more important to see that. Sorry? Oh yes, but I'm sure we are going to see more and more cases like this. We don't know where the microclotting is taking place and what has happened. Thank you, sir. Thank you, doctor. Yeah, oh sorry, there is another question, doctor.